Hello and welcome to today's webinar. My name is Trevor and I'm the Communications Manager for the Canadian Cancer Survivor Network. On behalf of CCSN, I would like to thank everyone for attending this webinar. If you're new to our webinar series, I will give you a quick rundown of our organization. CCSN, or the Canadian Cancer Survivor Network, is an organization that works with cancer patients and survivors to learn about the complexity of our health system, connect with others to plan action, and act on those plans to promote better healthcare and healthier survivorship. Visit survivornet.ca to learn more about our organization and the work that we do. There you'll find news, events, this webinar series, and much more. Once again, that is survivornet.ca. Before we begin, I would like to state that CCSN is based in Ottawa, Ontario, which is the traditional and unceded lands of the Algonquin and Anishinaabe peoples. Quick announcements: this webinar will be recorded and will be available on YouTube tomorrow. This video will be sent out to all who register, along with a copy of the slides. We will also have a short Q&A session after this webinar, but please don't wait until the end if you have any questions. Feel free to put them in the chat function and we will get to them at the end of this webinar. And now I am pleased to present Dr. Ambreen Sayani, MD, PhD, and she's a clinically trained social scientist specialized in health equity, patient engagement, and cancer care. She holds a 6-year career development award from the Canadian Institutes of Health Research to lead patient-oriented research in Canada. Dr. Sayani is a health equity expert advisor for the Canadian Partnership Against Cancer, a member of the Medical Advisory Committee for us here at the Canadian Cancer Survivor Network, co-founder of the Equity Mobilizing Partnerships in Community Research Affiliate at the MAP Center for Urban Health Solutions, St. Michael's Hospital, and is an adjunct professor in the School of Health Policy and Management at York University in Toronto, Ontario, Canada. And so without further ado, I would like to pass it over to Dr. Sayani to present our webinar, Equity-Orientated Lung Cancer Screening, Key Concepts and Future Directions. So Dr. Sayani, take it away.
Thank you so much, Trevor, for the introduction, and thank you to CCSN for having me back here talking about important topics. I'm just going to share my screen and we can get the show rolling. So I know we just have about under an hour today to talk about some really intense topics, and I thought I would just give people a snippet of some key concepts related to health equity. I find it's useful to align ourselves in the language before we speak about health inequities. I will then be digging into inequities across the lung cancer care continuum, consider approaches that are equity-oriented when it comes to lung screening, and I'll share some of my research with you and see how we can consider that in the way we move forward. So what are these key concepts, and why do we talk about equity in health in the first place, and how does it differ from health inequalities? Well, there are a couple of differences. When we talk about health inequalities, we're actually talking about differences in health outcomes, in health risks, and in mortality and morbidity. But those differences can occur between different groups of people for a variety of reasons. A health inequity is when that difference is because of social and economic and political policies that have resulted in the systematic, unfair, unjust distribution of resources amongst people. Ultimately, what happens then is that the resources
Dr. Sayani, I apologize, but you have been muted. Sorry for that.
How long have I been unmuted, Trevor?
Yes, you've been unmuted.
Sorry? Right from the start?
No, just you cut out about 10 seconds ago. So just from your last point, please.
So do I need to redo this slide or can I just move along?
Just move along.
Okay, perfect. So when we're talking about equal opportunities in terms of access to healthcare, it ultimately means that we need to be able to consider different dimensions of access that will allow people to have their healthcare needs met. These dimensions of access have been defined as approachability, acceptability, availability, affordability, and appropriateness. But what do they actually mean? Approachability means that a service exists that people know about, so therefore they can go and receive it. Acceptability means that the service is socially and culturally acceptable to people who need it. It is available at a time that it will be beneficial to people. It considers the direct and indirect costs related to access, and it is appropriate. So there's a fit between, well, what do I need from the healthcare system and is it going to benefit me versus what's on offer? And then for all of these different dimensions of access, we're asked to think, well, how do we create equal opportunities for everybody in all of these different dimensions, considering equities in health? Before I unpack that a little bit further, I have three key concepts that I want to share with everyone. This is the first one, social location. What is the social location? It is a rank order. It is specifically a hierarchical order that individuals occupy on a ladder in society. It is based on their levels of power, privilege, and prestige that they occupy in society. This allows them to accumulate social and material resources, and it allows them either to go further up the ladder, stay on the ladder, and unfortunately at times be pushed further down the ladder. These rank ladders are structured based on gender, race, ableism, just to name a few. What's also important is this concept of clustering of disadvantage. What you will often see is that individuals who are disadvantaged based on income are also the same individuals who are going to be disadvantaged in terms of education, housing security, and income and employment levels. How does this relate to smoking? Well, if we look at data related to smoking, you will see that neighborhoods that have high levels of smoking consumption are also those that report high levels of material deprivation, residential instability, and marginalization. How does that stack up based on social location? So disadvantage is going to cluster together. And with the clustered disadvantage also come health risk behaviors such as smoking. But it isn't quite so simple. Let's look at this phenomenon, which is the life course model of health inequities. And what that means is people don't just end up living with low education and low income. It means that during their childhood, certain social and economic policies created the environment that enabled them to access meaningful education. If they were able to receive that education, they were able to go further on into employment opportunities, secure better income, and secure stable housing. Across the life course, when an individual is disadvantaged, there is an accumulation of lower education, lower income, precarious work, and increased housing instability. So what does it mean to deliver health equity-oriented healthcare within this landscape? It means that I, as a healthcare professional and as a researcher, need to consider the distribution of the social determinants of health that underpin everything in terms of how people have access to resources. I need to consider that this is socially stratified. That means that there is a clustering of the disadvantage that happens. It also implies that I need to understand that all of this clustering leads to health risks, and that when people present in clinical encounters or in social services, they may be treated unfairly, they may experience discrimination and stigma because of those risky health behaviors, but that none of those actually have to do with their own personal choice, but how society has been structured and positioned them to be in that certain situation. Ultimately, it means I take all of those considerations and consider how do I reduce avoidable differences in access to care. With those key concepts that we've just discussed, I'd like to shift a bit forward to the lung cancer care continuum. The lung cancer care continuum goes from risky behaviors that lead to lung cancer risk, which includes smoking consumption, and then early detection, treatment, and then end-of-life care or palliation. And what I want to show here is the social gradient in lung cancer survival. What that means is if you look at the bottommost line on this graph, it is those that live with the highest levels of income. And if you look at the topmost line on this graph, it is those that live with the lowest levels of income. Those living with the lowest levels of income have the highest rate of lung cancer, and they're least likely to survive. What is also important is that you can see there's a widening of the gradient, so that more and more people who are living with lower income are more likely to die than those with higher income. How does that relate to the social location? Let's unpack this a little further. It is ultimately across the entire lung cancer care continuum that social location has an impact on lung cancer risk, mortality, and outcomes. Individuals living with lower income are more likely to be smoking, and we've discussed some of the clustering of disadvantage that happens in neighborhoods with material deprivation. When it comes to smoking cessation, almost every smoker will tell you that they've tried to quit smoking. However, statistics point that only those living in conditions of social advantage are able to quit smoking, and probably twice as much as those living in social disadvantage. What about opportunities to access screening? Income, rural location, gender, ethnicity, all determine access to screening. Lung cancer incidence is highest in those living with lower levels of income and lower levels of education. They're less likely to receive timely treatment and ultimately have high rates of mortality. So when we take an equity-oriented approach to lung cancer screening, we consider that smoking behavior is shaped by income and housing and access to resources. We understand that this is distributed socially and not individually. We also recognize and acknowledge that smoking is a heavily stigmatized behavior, along with lung cancer itself, where smokers who develop lung cancer go on to experience blame and shame. And to create equity-oriented lung cancer care, it means we intentionally create opportunities to reduce avoidable differences. In Canada, lung cancer inequities are predominantly occurring in populations that live in rural communities, those that live with lower levels of income, and First Nations, Inuit, and Métis people. What I want to show with this graph here, it's a lot of graphs, and the only point I want to make is if we look at the top graph on the left, and then you look at the bottom graph on the left, you can see that the difference, the gradient in lung cancer related to socioeconomic inequalities is widening over time, and this is particularly so for men. So what does that mean? It means that we inherently have inequities that occur based on the disease, but then we also see inequities that are widening. What do we do about that? There's something called a priority population approach. According to this approach, populations should be prioritized for care. And this prioritization is based on the burden of disease within that population, and that the efforts for outreach should be proportional to the disease burden. It means that we need to design interventions that are proportional to the disease by allocating resources and services based on that need. And how does this ultimately relate to lung cancer screening, which was the predominant topic for today? Lung cancer screening is the use of low-dose CT scan to create snaps of the lung, which take around 90% less radiation than a normal CT scan. And it has been found in two studies with high power, the National Lung Cancer Screening Trial and the Belgium trial out of the Netherlands, that have shown sufficient power to reduce mortality related to lung cancer with the use of low-dose CT. In Canada, lung cancer screening is currently being pilot tested in a few provinces and has been set up as a provincial program in Ontario and more recently in British Columbia. In each of these programs, the Canadian Task Force on Preventative Healthcare recommends that people who are at high risk should be eligible for lung cancer screening. That means people who are within the ages of 55 to 74, have smoked over 30 pack years, should be eligible to receive low-dose CT for up to 3 consecutive times. This is a very complex pathway that I don't want to get into, but what it ultimately points to is the fact that people who are eligible must be identified by a primary care provider, who will then refer them to lung cancer screening, and then they go through a whole circuit within the healthcare system in order to find if they had anything positive on the CT scan or not. When we depend so heavily on the healthcare system, we run a chance of inducing health inequities that are generated by the system itself. What this means is that even though we have a disease that is inequitably distributed, we then introduce an intervention such as lung cancer screening into the population, but because its uptake is inequitable, because of the way it's designed, we can generate further inequities that will widen the gradient between those that have resources versus those that don't. So lung cancer screening presents two very specific health equity challenges. The first is a distribution of disease that is proportionate to the degree of social disadvantage, and then an opportunity to screen for the disease, but in a target population with a low uptake. So these two things will work together to create a perfect storm, whereby which we can drastically and quite significantly increase the gap between those who are socially advantaged versus those that are not, unless we take specific considerations. And for lung cancer screening, this means that populations that have the highest burden of lung cancer risk due to the social patterning of smoking consumption need to be prioritized for the intervention. And that we need to consider barriers in access that are related to the economic, structural, and geographic barriers that people face, along with the stigma that people face during clinical encounters in social services. Ultimately, what does it mean to have equitable access to lung cancer screening? It means that any person who is eligible to have lung cancer screening should be able to receive it in a timely way. It means that the service is approachable and people know of its existence. It is socially and culturally tailored to people based on their needs and preferences. It is available in a timely way to everyone at high risk. It considers the direct and indirect costs and ultimately empowers people so that they are in charge of their healthcare decision-making. With that, I'm probably going to shift to the second leg of my talk today, which is about some of my research. And this should probably open us up to some more questions towards the end. In my research, I work at the interface of social and health inequities across the cancer care continuum. I study all types of cancers and I study all types of inequities. The focus of what I'm going to share with you today is my work across the lung cancer care continuum with an emphasis on lung cancer screening. And I'll be sharing 4 studies with you. So this is the first one. This is a scoping study in which our research question was, what are the health impacts intended or unintended, or positive and negative, of interventions designed to increase the uptake of lung cancer screening on priority populations. To do this, we conducted a scoping study. We looked into all of the published literature from the year 2000 onwards. We looked at gray literature as well, and ultimately came out with 36 articles that described interventions that were specifically designed to increase uptake of lung cancer screening. And what did we find? Well, if we look at the dimensions of access that are approachability, availability, affordability, acceptability, and appropriateness, what we found was that there was limited outreach in the design of these interventions to priority populations. There was little to no tailoring based on sociocultural practices. There were few methods to reduce financial barriers to care, and little fit between the intervention design and underlying patterns of health inequities. Another research question that we had was, but what influences the choice to participate in lung cancer screening for individuals living with low income and at a high risk of developing cancer? What we know is that individuals living with low income are more likely to smoke. We also know that they're less likely to access lung cancer screening. But what is it that influences their choice to participate in it or not when they're given the offer? So we interviewed people in downtown Toronto who are eligible for lung cancer screening, and we broke them up into two groups: those that, when offered the opportunity, decided to participate in screening, and those that declined participation in lung cancer screening. And what I will share with you next are some of their quotes and some of the insights. But before that, when we went into this study, we went in knowing and recognizing the social structure of low income and the clustering of smoking behavior. Therefore, we acknowledged all of the social inequities that underpinned the behaviors and patterns that we were seeing. Individuals in the study described how housing was a key determinant of their smoking status and their willingness to participate in lung cancer screening or not. As shared by this participant, who tells us he was working as a subcontractor, he was paid by the job. When he got sick, he lost his job. And when he lost his job, he lost his income. Subsequently, he lost his housing. And therefore, individuals who are struggling to meet their day-to-day ends are not going to prioritize a preventative healthcare service such as lung cancer screening. People also spoke to us about the upstream determinants of lung cancer risk and early detection. Because smoking is such a high risk factor, almost everybody described the conditions under which they were smoking or they were able to successfully quit smoking. So much of this has to do with the lived environment that people are in, as shared by this participant who says he quit smoking, then he moved into a building where there was so much drug dealing going on, and so many people were smoking that he started to smoke again. And lastly, but certainly not least, participants in this study described how space of the clinical encounter could be so unsafe that they were stigmatized, further marginalized, and refused to seek care ever again, as described by this participant who says he got treated really badly and didn't want to go into another office and be treated like a piece of garbage. Therefore, whereas we've known that lung cancer screening was individuals' choice to participate in lung cancer screening can be influenced by the healthcare provider. It is also influenced by life outlook and living conditions. Using a social inequalities lens allows us to understand that people aren't living in poor living conditions out of their own choice. They've been structured to live in that way, and that their lived environment influences their smoking behavior and screening perspectives. This also goes on to influence whether they have a safe clinical encounter or not, whereby clinicians who hold power and influence over them can treat them with bias and stigma, or treat them with respect and build trust and influence positive decision-making towards lung cancer screening. This is a third research study that I'll share with you. And in this one, we asked, what are the perspectives of family physicians towards access to lung cancer screening for individuals living with low income? And in this study, we spoke to family physicians who practice in downtown Toronto, mainly serving the urban inner city and people living with low income. We asked them, what goes on in the clinical encounter? And why would people choose to screen for lung cancer or not? And there were a couple of themes that came out of this study. The first was social disadvantage. Physicians recognize that individuals living with lower income have higher health risks, and they lack resources to seek care. They also know that the time in the clinical encounter is basically spent solving acute problems, and that if they are more practitioners along with them within their clinical space, such as a nurse practitioner, a social worker, they can probably offer more value in terms of preventative healthcare. Almost every physician spoke about the need to improve access to care and the need to improve degrees of social disadvantage within society. What was really intriguing from this study was that although well-positioned, physicians tended to place the blame of smoking and the choice to quit smoking on individuals. There was a gross neglect of the social structural inequalities that were shaping the risky behaviors or the ability to choose to make healthier choices. All of these studies together build up to this final research question that I'm going to share with you today. And this is an ongoing research study, which is how can we partner with patients to educate providers so that lung cancer screening is offered in a more equity-oriented way? And this is my work that is currently ongoing. We're partnering with patients, partnering with health service providers, policymakers, and decision makers for lung cancer screening at the Ontario provincial and federal level in Canada. And we are designing an e-module. In this e-module, we are working to create a platform that will educate providers on how to deliver equity-oriented lung screening. Through this, patients who are partners on this project are educating providers to understand their lived experiences, so that providers are better equipped to understand the social determinants of health and the systemic policies that have led patients to be in the position that they're in. Also within this module, patients are talking to providers and educating them on how to make the clinical encounter more safe by not perpetuating bias and stigma within that encounter. And finally, patients are teaching providers how to build on their own personal strengths so that they can move forward in an empowered way to improve their own health together with the provider, which is ultimately where we all want to go with lung cancer screening. Where are we at in terms of this e-module? We are ready to pilot test this module in January, and then we will be implementing it across Ontario over the next 2 years. Subsequently, we will evaluate it and scale at a national level. So let me wrap up with just some key considerations for anyone working in this space. We need to reduce inequities in lung cancer care. To do this, we need to target outreach to priority populations. We need to tailor interventions based on social and cultural practices. We certainly need to reduce financial, time, and geographic barriers. We must design culturally safe smoking cessation programs in a way that meets patients where they are on their journey of smoking cessation, rather than where the healthcare provider wants them to be. If a person is diagnosed with lung cancer, it won't be any good if we just have lung cancer screening, but none of the other services to support people living with low income to access the whole continuum of care. Ultimately, we need to advocate for better policies so that we can reduce the upstream determinants of lung cancer risk. When it comes to lung cancer screening, interventions definitely must always consider the disproportionate burden of risk in the populations. Unless we do that proactively, and I would argue unless every lung screening program puts on that lens before they sit down to do the work, we run a huge risk of widening the gap. We must target interventions to support uptake in high-risk populations. And simultaneously, we need to advocate to reduce the structural drivers of risk, including what is perpetuating smoking, what are the conditions that allow people to smoke, which are the conditions that prevent people from smoking cessation practices, and what happens when people want to access lung cancer screening but just don't have the resources to do so. So with that, I will stop sharing my slides and maybe open up to some conversation.
Thank you very much for that talk. And I know from personal experience that I've worked many jobs, especially also in the restaurant industry, and I found that the higher up the ladder you work up, sometimes you find that there is less smoking going on, and that and especially in a service industry area where where smoking is very pervasive, doesn't matter the type of job, the precariousness of the income, and the income disparity definitely plays a role in that kind of in smoking. We do have one question, and yeah, it says, I have a male friend who got lung cancer. He's not a smoker, healthier, blue collar employee, but he got lung cancer. So for these people who are in blue collar situations and jobs, but don't smoke, how could it be that he can get lung cancer as well?
So, although smoking is one of the highest risk factors for lung cancer, there are many other determinants, and employment, occupational risks, stress associated with precarious employment certainly contribute to higher cancer risk. And there are a variety of reasons for that. Again, you're going to see a social gradient across all kinds of lung cancer, whether it is smoking related or not. It's just that with smoking, you're going to see a wider gradient.
Now, I know that you touched briefly on the amount of research that is and the models that you're doing, but is there anything else in the work that you are spearheading in terms of finding this equity approach to lung cancer screening and lung cancer? Is there any other next steps that you'd like to share with them?
Work, any advocacy work needs to go in tandem with the research. I view research as a tool for advocacy. So when my research points to the fact that interventions are missing the bar in terms of how much they engage with populations and communities, I would say, well, it's important to consider how are you engaging with populations and communities, and how can you engage better? How can you include community voices better in your work? So I advocate for that. I also advocate for health system redesign. So for example, if we're designing healthcare interventions, such as lung cancer screening, sitting in an academic office and making assumptions about issues related to access from our privileged table, it's going to miss the bar again, because we don't have those lived experiences to understand what those barriers to access are. So let's redesign policies and interventions, including people that are most excluded, and let's bring them on the table. So redesigning health systems in a way that meets everybody's needs is also a key priority. I think the last piece that I'd say is evaluation is often an area where people in ivory towers will craft the metrics. What should be evaluated? How should it be evaluated? Who should be evaluating? I think even those evaluation questions need to be crafted with community in terms of their needs and priorities, particularly the most underserved when you look at lung cancer screening. In order for it to be beneficial for everyone, they need to be telling us what is important, what should be measured, and what level of change would be significant to meet their needs.
Do you find that it's part of a trend for this more kind of grassroots kind of research into these kind of origins, not just with lung cancer, but across the medical field? Or is this something that you feel that is kind of new and revolutionary that they're doing?
So Canada has a national strategy for patient-oriented research, and part of that strategy is to make sure there is no research being done without patients. And it goes from the quote, "Nothing about us without us." For too long, healthcare service researchers and decision makers have tried to do this without the patient, and patients have had research done on them without them, or have had health services designed for them without them. And so the National Strategy for Patient-Oriented Research really puts a disruption into that way of thinking, saying, well, you need to include patients, because unless patients are on the table, you don't know if you're asking the right and meaningful questions. And this is, as part of the strategy rolls out more and more research, teams are being asked to include patient partners to justify who the patient partners are. And from my perspective, I always argue and say, well, consider who from an equity-oriented lens needs to be on your table and who isn't there, and what will you do about that to include them in your research and design?
Well, yes, well, there was one other question. To address shared decision-making, empowering the patient, how to move towards this from an equity-oriented lens. So I guess, how would, in that sense, how can we kind of move that lens? Like, what can patients do per se, and groups do to move the lens, and how to make it more equity-oriented?
Making, if I get the question correctly, to make decision making more equity oriented, more shared decision making that is equity oriented?
Yes, absolutely.
Right. So I would say consider the decision. What is it about? And when it comes to lung cancer screening, we can say that eligibility criteria based on smoking. So therefore, individuals who are smokers should be on the table for decision making. And individuals who've been unable to quit or who decide not to participate in lung cancer screening, they're the ones who should be on the table in order to design and rethink in a way that matches their needs. Are we even asking the right questions or not? So an equity-oriented approach really asks you to think, well, what is the decision about? Who is it about? Who is most affected by this condition or illness? And then how do I make the most efforts to go about and reach out to them? Sometimes this includes a whole period of relationship building. How do I build those relationships and connections so that I can leverage the trust and invite people to discussions and conversations about this decision? So it's a bit of a 2 or 3-pronged approach. A, consider your decision, who's being impacted by the decision, who bears the burden of the illness, and then consider who's most excluded from your decision-making table right now, and do that amount of outreach to include them on the table. And then sharing space on the table is a completely different piece, which means that your table is power sharing, does not discriminate, and considers implicit bias and allows everybody to share their voices and opinions in a trustful manner.
Well, excellent. If there's no other questions that I see, I think that have any case studies where have there been any case studies where this has been done well, like the gold standard case study for this so far?
for shared decision making?
Yes.
I can say decision making and any kind of community or patient engagement practice is going to be relationship based. And therefore, building networks of trust and grounding that in relationships is super important. Is there a gold standard to any marriage that's based on relationships? No, not really. You just need to understand the dynamics. I always say there isn't a gold standard and there isn't a best practice, but there's certainly a book of don't do this. And I like to talk about that book because when you do certain things, you perpetuate bias and you create harms. So I would say this conversation needs to move from one of gold standard and best practices to one of let's not do harms, let's create safer spaces, and let's build trusting relationships. That being said, I've co-initiated a community called Equity Mobilizing Partnerships in Community. I say co-initiated because it was co-designed with structurally underserved communities. So it's a diverse voice. It's a community table of diverse voices. It's inclusive in its design because it was co-designed, and I'm happy to put that in the chat. And maybe Trevor, I can share the link with you later if people would like to read more about how such a community could be co-created and co-designed that is equity oriented and that builds grassroots up to inform healthcare decision making.
Absolutely, and then we can definitely share that link with everyone who registered. Everyone who registered, of course, is going to be getting a copy of this webinar and the slides as well. So I'd like to give a very big thank you to Dr. Sayani. This has been a very eye-opening topic. Now, this is one of the last webinars in our series for 2022. I do believe we have one more left until we wrap it up for the year, and we are also planning 2023 as well. So stay tuned for that. We have a lot of very interesting topics. And once again, I'd like to thank Dr. Sayani once again, and hope that everyone here has a fantastic day.